So good day, everyone. Welcome to our webinar on finding the sweet spot. We will get started in just a little bit as we're waiting for folks to enter the room. All right, good day, everyone. We're going to get started. We may have people join us as we go along, but I'm really happy to kick off our webinar today with Dr. Andrea Schwartz. And the webinar's entitled Finding the Sweet Spot Using Medicare Wellness Visits to Promote Diabetes Prevention in Older Adults. Next slide, please. So I am Christine Reedy. I'm the director of the National Center for Equitable Care for Elders, or NCECE. And we are a HRSA-funded national training and technical assistance partner who provides training and technical assistance to our nation's health center with the focus on older adult care. And you can see here in this slide, you can connect with us through social media, Twitter, Facebook, as well as email us, and then also to check out our website for various resources that we have. Next slide, please. So we just wanted to highlight that as part of the National Training and Technical Assistance Partners, we add material to the Health Center Resource Clearinghouse. This is a great resource for you, not only for COVID-19 resources, but we do want to highlight those, but also for other types of resources, and particularly for our focus area, which is under the special and vulnerable populations. So please check out the clearinghouse. A lot of material is added from time to time, including webinars and publications, as well as for those who are in health centers, potential learning collaborative opportunities. Next slide, please. So to kick off our session today, just a few reminders. Please use the Q&A or the chat box to ask a question during the session. And Dr. Schwartz has told us that she's an individual who engages with her chat box. And so feel free to chat out a question or a comment during her presentation. We will record the webinar, and it will be available. We'll email it to participants. And then at the end of it, we do have an evaluation because we are a HRSA-funded center. They would like to hear back about our training and technical assistance opportunities. And we also ask you to provide suggestions for other types of topics focused on caring for older adults that you might want to hear about. So please fill out the evaluation at the end. We'd love to get your feedback. And next slide, please. So without further ado, I'm going to turn it over to Dr. Andrea Schwartz, who is the medical director of the geriatrics clinic at the VA Boston Healthcare System, and a new role, associate director for the clinical innovation in the New England Geriatrics Research Education and Clinical Center. Dr. Schwartz leads the aging and end-of-life theme at Harvard Medical School as a Harvard Medical School faculty, and is a national leader in something that we here at NCECE really try to promote, and that is the Age-Friendly Health Systems Initiative. So Dr. Schwartz.
Thank you so much, Dr. Reedy, and I'm delighted to be here today. As I'm pulling up my slides, I would love to get a sense of who is in the Zoom room. So I invite you to just type into the chat your role and where you're zooming in from to give me a sense. And I do see that we have a request in the chat to turn on the closed captioning. So I will ask the wonderful team from the National Center to help us with that. And as you're chatting in your names and where you're zooming in from and your roles, which will really give me a sense of who's in the Zoom room, I'll share that our topic for today is called Finding the Sweet Spot, because we're going to be talking about how we can improve diabetes care for older adults by leveraging the Medicare Wellness Visit. I'm going to put up my disclosures, which is that I serve on the faculty for the Institute for Healthcare Improvement's Age-Friendly Health System Action Community. And I also want to acknowledge my co-authors who helped develop some of the materials I'll be sharing today from the American Geriatric Society Diabetes Quick Guide and a publication on MedEd Portal. So you can see them listed here, and I'm grateful to that wonderful interprofessional team. Thank you to all of you who are chatting in. It's wonderful to see what a diverse interprofessional group we have, and both geographic diversity and different professions. While you continue to do that, I'll share that these are our learning objectives for our time together. And I'll just give you an overview of how we're going to approach finding the sweet spot. We'll spend a short time on the impact of diabetes in older adults, which I imagine is well known to all of you zooming in today. And then we'll spend time talking about the 4 M's of age-friendly care and how it relates to diabetes, followed by how we can integrate that approach, that age-friendly approach to diabetes care, into the Medicare Annual Wellness Visit. And finally, we'll present a framework on how to find that sweet spot in diabetes management for older adults. So I want to thank all of you who've chatted in your names and professions, and I really congratulate all of you for your dedication to equitable care for elders. It's a wonderful community to be a part of, being dedicated to that important goal. So I'm going to get us started by reviewing the impact of diabetes in older adults. And I think one of the most important things to remember is that we're really talking about most older adults in the United States. 25% of older adults have a diagnosis of diabetes, and another 50% have pre-diabetes. So that does mean that 3/4 of older adults in the United States need to think about diabetes as something that can really impact their health now and in the future. So these statistics may be familiar to you, but a reminder that people living with diabetes are at risk of premature death. And that can come through an increased risk for heart attacks and strokes. But even though it can be a chronic illness that people live with till very old age, it can cause life-threatening complications. Functional disability is also a risk that older adults living with diabetes may face, in that diabetes itself can impact their vision through retinopathy, their kidney function through nephropathy, their nervous system through neuropathy, and all of those can make it harder to function and live independently as we age. We also know that diabetes may lead to accelerated muscle loss, and we'll speak a little bit about that when we talk about mobility. And that many people living with diabetes also have coexisting illnesses or comorbidities that are affected by the diabetes and that affect the diabetes. And we'll speak about this. And indeed, for older adults in particular, living with diabetes means that there are increased risks of some of the geriatric syndromes that we'll highlight during the session today, with a focus on polypharmacy and the way medications can impact our diabetes management. I'm guessing, based on the list of professions I see in the chat, that most of you are well aware of the importance of diabetes in older adults. And so I want to spend the most of our time today focused on what we can do about it to improve care for older adults with diabetes or at risk for diabetes, leveraging the annual wellness visit and using this novel framework of the 4 M's of age-friendly care. So I'm curious, among those of you who've joined today, how many of you are familiar with the Age-Friendly Health Systems Initiative? I imagine that in the group here today, some of you are very familiar, maybe you're even part of the action communities that the Institute for Healthcare Improvement runs. But I imagine for some of you, this framework is new today. So I'll spend a moment just to make sure we're all up to speed on it. The Age-Friendly Health Systems Initiative was started in 2018, so it's relatively new, by the Institute for Healthcare Improvement, along with several other healthcare partners. And it aims to implement the 4 M's of age-friendly care that you see here to the care of all older adults in every setting in which they receive care. And if you imagine an older woman that you are involved with her care, or maybe she's a family member of yours, you can imagine all the incredible life experience, adversity she's had to overcome, wisdom that she has, communities that she's formed. And you can imagine that if she's got diabetes on her problem list, you've got the abbreviation here, diabetes mellitus, it can really impact her life and her ability to do what matters to her. And if you layer on a long list of comorbidities, and this is a very common list of chronic conditions that older adults might be dealing with, you can imagine that the diabetes becomes the tip of the iceberg in some ways in helping her age with a focus on what matters to her. So I want to congratulate those of you that are aware of Age-Friendly, and I see that Bay State's been recognized as an age-friendly health system, which is wonderful. And while I won't speak in detail about it today, I do encourage you to learn more about this framework because it allows us to take a step back from that overly medical focused problem by problem approach that can often miss the forest for the trees, and helps make sure that a person like the one pictured here is going to get healthcare that aligns with what matters to her and enables her to attend to her mobility, mentation, and medication as she ages. So I'm going to speak a little bit about how each M impacts diabetes care and is impacted by diabetes care. And feel free to put your questions in the chat as we go. I'm going to start with mobility. And I invite you to think for a moment and put in the chat, how does mobility affect diabetes? And how does diabetes affect mobility? And it's really a two-way street, as we'll see. And we'll see that all of the M's interact with one another and really ought to be thought of as a set. You can't think about mobility without also thinking about what matters and medications and mentation. But we'll start our conversation with mobility. And then I invite you to put into the chat any ideas you have from your experience, and I see there's a lot of it, thinking about how mobility affects or is affected by diabetes. So I see a wonderful suggestion from Taryn that neuropathy, which affects our nerves, can indeed affect both our fine motor skills, our dexterity for things like administering insulin, as well as our fall risk when it comes to finding where we are in space, our proprioception. So that's a wonderful example to start us off with. And I see a wonderful suggestion from Jean about maintaining physical activity, which can, of course, improve your sugars, lower your risk of getting diabetes. And mobility determines what kind of exercise you're going to be able to do. Thank you, Amy, for that comment. I can see we've got a wonderful group with terrific comments to add. So keep them coming. I organized them in 3 categories. That exercise, of course, has a beneficial impact on diabetes, a green light there that it lowers the risk of diabetes and, of course, improves our glycemic control. But then, of course, as has been mentioned, our difficulties with dexterity that may come as a result of neuropathy can make it more difficult to organize, take medications, or deal with insulin. And that, as I see, another person, maybe Jacobo, has entered into the chat, is reduced muscle strength, which can increase the risk of falls in people with diabetes. And both hypo, low sugars, and hyperglycemia, high sugars, can lead to falls in people living with diabetes, as well as neuropathy, as we've mentioned. So that's an overview of the two-way street between mobility and diabetes. And you can't care for someone living with diabetes or at risk for diabetes without thinking about these domains. Exercise, of course, we know is the fountain of youth and something that you're never too old to benefit from. In fact, the oldest and frailest people have the most to gain from engaging in exercise as safe to do so. There's a wonderful quote by a geriatrician named Dr. Maria Fiataroni, who says that exercise is much safer than inactivity when it comes to health and well-being. So rather than seeking permission to exercise, you should really have to seek permission to be sedentary. And I love this quote because it reminds us that any bit of exercise we can encourage and empower our patients and the older adults in our lives to do is going to be helpful. And so coming up with exercises that they're able to do to start small, to partner with them, to figure out barriers to being physically active can make a huge difference. Before I move on from this slide, I also want to acknowledge what Trudy put in the chat, that mobility is a much larger category. While it includes falls and it includes exercise, it also includes just getting around, functional status, being able to care for yourself. And so someone who is having difficulties with mobility, whether it's in the big picture, they're having difficulty driving because of their vision, or in the small picture, they just can't get down the stairs of their house, they're going to have more difficulty getting to their healthcare appointment. They might even have more difficulty engaging in telehealth if they've got vision impairment. So mobility is such an important category to be thinking about in our patients living with diabetes or at risk for it. I'm going to review a couple of ways we can assess mobility in older adults at risk for or living with diabetes. And since we've been on the Zoom for about 15 minutes, if you're willing, I'll ask you to try this one out with me. This is called the chair stand. And this picture here is from a piece we did with one of our geriatrics fellows, Dr. James. It's a picture of her and her dad, who is our model for this video. What you can do wherever you're zooming in from, if you're able and if safe to do so, you can cross your arms over your chest and try to stand up from your chair without using your arms. Now, be careful if you're on a wheelie chair, and then go ahead and sit back down again. And this simple mobility assessment can both tell you who is at high risk for a fall, someone who can't even do one or who takes a long time, and will also tell you who would benefit from practicing this exercise. And so I often encourage my patients to participate in the chair stand as a way of improving their fall risk. So it's both diagnostic and therapeutic. And I'll usually give my patients this handout, if you can see on the slide, from the CDC's STEADY initiative, freely available, and it'll teach patients how to do this chair stand exercise. So that's an example of a very small thing we can teach our patients at risk for or living with diabetes to lower their risk of falls and improve their overall mobility. But then we also need to think about that dexterity and thinking about whether it's getting easy open caps for their medications or working with our occupational therapy colleagues to help them manage insulin, which can take a lot of dexterity. Those sorts of changes can really help with adherence and compliance. Now, we could spend our whole time talking about mobility, but I want to make sure we're able to address all 4 M's. So we'll move on now to the next M of mentation. Again, thinking about it in the context of all 4 M's. So thank you, Tiff, for sharing the CDC study link, and that's fantastic. And let me invite all of you to share, how does mentation affect diabetes, and how does diabetes affect mentation? And mentation, of course, is a broad umbrella that includes things like dementia and cognitive impairment, depression and mood disorders, as well as delirium, risk of confusion in older adults. So I invite you to put your ideas in the chat. How have you seen diabetes affect mentation or be affected by mentation? And while you're putting in those ideas, I'll start us off with one very common one, which is diabetes and cognitive impairment. We know that older adults with diabetes are at a higher risk of cognitive impairment and long-term care placement. And we know that people living with cognitive impairment and dementia have a more difficult time managing their diabetes because it can be difficult to perform the complex self-care tasks required to monitor one's sugars. It can be difficult to maintain the appropriate timing and content of one's diet. And so we know that in older adults living with both diabetes and cognitive impairment, we need to think differently about how we manage the diabetes. We often need to simplify regimens, look at less stringent glucose goals, and involve caregivers, involve an interprofessional team. Taryn's given another excellent example of how diabetes can affect mentation, that if you've got very high sugars or very low sugars, you can get very confused. And if your brain is old, or if your brain is vulnerable because you've already got an underlying cognitive impairment, you're much more likely to experience delirium or become more confused in that setting. I'll share a brief story based on some patients that I've cared for, though I'll change all identifying details, of a patient who already had a diagnosis of Alzheimer's disease and had what we would call moderate dementia, where he was able to dress himself and bathe himself. But then over the course of a few days, he became extremely confused, was unable to do basic tasks or even recognize his wife. It was a sudden change. And her quick thinking led the team in the emergency room to discover that he was hyperglycemic. His sugars were up in the 500s. And that was what had led to the sudden change in his cognition, not a progression of his dementia, which progresses over months to years, but rather confusion because of his sugars. He turned out to have an infection, which as it was treated, his sugars came down, his mentation improved. So absolutely, diabetes and mentation are so closely linked. In anybody with diabetes, it is important to establish their baseline cognition, because if they have cognitive impairment, we need to know so we can modify their treatment accordingly. A quick screening tool that you can do when caring for someone with diabetes is the mini-cog. The mini-cog is nice because it just consists of a 3-word recall and a clock draw. And I'm actually going to have you try it with me so you get a sense of what's involved and how quick it is. So from wherever you are zooming in, I'm going to make sure that you've got your hearing aids and your glasses if you need them, and that you're in a comfortable spot where you can hear me. And I'm going to tell you 3 words, and I'm going to ask you to repeat them back to me and try to remember them. And then I'll ask you for them again in a few minutes. Are you ready? The 3 words are banana, sunrise, chair. So go ahead. I won't be able to hear you, but you can go ahead and say those words out loud. If I were doing this with a patient, I would give them a second attempt. And then what I'd like you to do is take out a piece of paper and something to write with. Could you please draw the face of a clock, put in all the numbers, and set the time as 10 past 11. I'm going to give you a moment to do that, and I'll repeat the instructions. Draw the face of a clock, put in all the numbers, and set the time as 10 past 11. Now, hopefully you've had a moment to draw your clock. I'd probably give a little bit longer if I were with a patient, because I'd be watching them do it. But since I can't see you, I'm now going to invite you to repeat those 3 words. You can put them in the chat if you want. But if I were doing this in person, I would have you just repeat what those 3 words were. Ready? So hopefully you were all able to recall banana, sunrise, chair. Now, don't worry, if you weren't able to, there are lots of reasons why people might not do well on the mini-cog. It has to do with whether we're stressed, whether we're paying attention, whether we're in pain. So don't worry if you didn't get it right. But when we do this with a patient, we get a lot of information about their cognition. First of all, if they have difficulty with the 3-word recall, they're probably going to have difficulty remembering what we tell them. So for that patient, we want to write important things down, and we want to pursue longer testing, potentially with a MOCA or a fuller workup for their cognition to see if they've got underlying cognitive impairment. But we also learn a lot from the clock draw. This is a picture taken from a patient where you can see that this patient, while their clock wasn't too bad, they couldn't quite get their numbers lined up. So the 12 and the 6 and the 3 and the 9 would be even. And they couldn't quite get the shorthand, longhand, which is actually quite a complicated task that requires abstract thinking and executive function or planning ahead. So somebody with an abnormal clock draw is probably going to have difficulty with a complex medication regimen. It's kind of like a stress test for the brain to see how well they can think. So anyone whose mini-cog is abnormal, typically we would do a longer cognitive assessment, and we would look for explanations of what could be affecting their cognition. Their hearing, their mood, their thyroid. There's so many things that can affect cognition. Their sleep apnea. but their diabetes could also be affecting their cognition. Their sugars could be too low or too high, and it might not be giving them the optimal chance to have the clearest thinking. So that's one way mentation is really important for diabetes. Another is depression and diabetes. The first quote on this slide is actually from the CDC's diabetes website. It reminds readers of the mind-body connection, that untreated mental health issues can make diabetes worse as people don't engage in self-care. And problems with diabetes can make mental health issues worse as people may be dealing with stress or frustration. But fortunately, if one gets better, the other tends to get better too. And so identifying and treating depression or other mental health issues in our patients at risk for or living with diabetes can help us make sure that they get the care they need. There have been some interesting studies looking at a major gender gap when it comes to diabetes in older adults, that it's actually women who are more likely to be diagnosed with depression among people living with diabetes. And one of the thoughts around the gender gap has to do with obesity, overweight, and alcohol use, that those may impact the widening gender gap. So there's a lot of important work to be done in this area, but it gets us thinking that in anybody at risk for or living with diabetes, we want to check in on their mood using a validated screening tool such as the PHQ-2 or the generalized anxiety screen, or if indicated, a PTSD screen, which I see a lot in my practice at the VA. And so thinking about mental health and depression in our patients living with diabetes can make sure they get the help and support they need. Feel free to put any questions in the chat you have. We're going to move along to medications, and I'll just make sure you can still see my slides well. For medications, I invite you again to think about the complications that arise when you throw diabetes into the mix. You may remember the sample patient I got you to think about, and how she had a very long list of medical conditions, which meant she had a very long list of medications. And this is very common. Most older adults are on multiple medications, and many are on more than 5, more than 10, and really experiencing polypharmacy. So one of the important things I'd like us all to think about when it comes to polypharmacy and diabetes is to always be suspicious that the medications could be causing more problems than they're helping. As geriatricians, we love this saying: any new symptom in an older patient should be considered a possible drug side effect until proven otherwise. And I like this idea because it gets at the worry that when someone presents with confusion, with falls, one of the first questions we need to ask is, have there been any changes to their medications recently? Maybe they had an infection, got more confused, and took too much insulin and got hypoglycemic and fell. So it's all quite interrelated and complex. And so medications always need to be reviewed to make sure older patients are getting more benefit than harm. There are many tools available to manage medications and ensure medication safety in older adults. I'll mention one that I think everyone on this webinar should know about, which is the American Geriatric Society's Beers list for potentially inappropriate medications. It's updated every 3 years. The 2022 update is likely close to being completed. And it's named after the late geriatrician, Dr. Mark Beers, who noted that there were certain classes of medications that cause more problems in older adults and ought to be used with caution. Excuse me. Now, you can probably name in the chat some categories that we know are high risk, not only for older adults, but for everybody, medications like opioids or benzodiazepines. But there are some medications that pose a particularly higher risk in older adults living with diabetes. And thank you, Tiff, for sharing that link. So for example, sliding scale insulin, which we see often prescribed in the hospital or nursing home setting, can pose problems for older adults because it is very reactive to high sugars, and it can sometimes lead to a dip with low sugars, and is very complicated and burdensome to administer. So there are actually very few circumstances where sliding scale insulin would be the best choice. And you can read more about it at the link that Tiff put in the chat. Another common example is some of the oral medications, some of the older medications like the sulfonylureas, which can cause hypoglycemia, low blood sugars. There are often safer alternatives that can be used in older patients depending on their overall picture. So tools like the Beers List can help you identify high-risk meds. And then tools like deprescribing.org can help you taper off and monitor meds that are no longer necessary. Because deprescribing a med ought to be done with the same caution as prescribing a new medication, because there can be withdrawals and side effects from removing a med. Though sometimes removing a medication helps a person feel better and helps them do more of what matters to them. You'll have a copy of this slide, of these slides, so you'll be able to see more of the resources available for medication management in older adults with diabetes. But the bottom line is to think about the medications broadly and involve your interprofessional team. Hopefully, you've got access to a nurse, a pharmacist who can help optimize medication management in older adults at risk for or living with diabetes. So that brings us to the fourth M, which is what matters. And really, this is the most important M. All of our efforts are really meant to help older adults do more of what matters to them as they age. Many of you are familiar with advanced care planning in the What Matters bucket, and that's the idea of making sure every person of every age has a healthcare proxy, a designated decision maker, if they're not able to make their own decisions, and also making sure that an older adult has advanced care planning on file so that the healthcare team knows their wishes when it comes to end-of-life care, like CPR or do not resuscitate considerations. But I'm not going to talk about that aspect of what matters today. I'm going to talk about an aspect called current care planning. And this is the idea that an older adult living with diabetes may have multiple priorities. And so this is drawn from the work of Patient Priorities Care, led by Dr. Mary Tinetti and others. And Patient Priorities Care, and Tiff, you could put the link in the chat for it, takes a patient who has multiple medical issues, including diabetes, and multiple different providers, and is maybe getting conflicting messages. In this infographic, you see the primary care doctor says, no need to start insulin. The endocrinologist says, well, we need to start insulin. Well, how do you prioritize? How do you decide? So in Patient Priorities Care, the idea is that you ask the patient what matters to them, not just at the end of life, but right now. What are the things they want to do more of? What are the things that they want their healthcare to help them do more of? So in this sample patient's case, Mr. K wants to feel well enough to spend time playing with his grandkids, to help his wife with housework, to have energy to go out to visit friends. And so in the Patient Priorities Care model, that's how we measure success of our healthcare. Not in sugar levels, A1C goals alone, but in do those better control of the sugars enable him to do more of what matters to him. And so this model has been studied in a variety of different settings, and ultimately has been shown to be a really promising model for coming up with actionable healthcare goals so that all of our healthcare, all of our diabetes care is helping our older adults do more of what matters to them. So thank you for putting the link in the chat. And I think it's a really wonderful model for making sure that what matters to our patients is at the center of everything we do in an age-friendly health system. So as we wrap up our discussion of the 4 M's, I'm going to add one more M just to complicate things, which is the 5th M that the American Geriatric Society adds and calls it the geriatric 5 M's. The 5th M is multi-complexity. And while it kind of overlays all 4 M's, I think it really bears mentioning at this webinar when we're thinking about equitable care for elders. Multi-complexity includes several concepts, including the social determinants of health, which are likely familiar to you all, but you see them listed here. And I'm sure I don't need to tell you how much each of these domains can affect an older person at risk for or living with diabetes. Just the higher risk for diabetes, the disparities we see in Black Americans, for example, has to do with the kind of neighborhoods that redlining may have led to, and the kind of access to fresh food and exercise paths and healthcare, let alone education and healthcare quality that a social and structural racism may have led to. So I think it's important to take that 5th M into consideration because it can affect both the risk for diabetes and the way someone is able to manage it and treat it. And while I'm not doing this topic justice today, I think when you think about the 4M's of age-friendly, this fifth M of multi-complexity is consider. Particularly, the social determinants of health interact with our model of geriatric syndromes. The social determinants of health affect whether someone is likely to smoke or be physically active, or what their BMI is likely to be, whether they can afford their medications, what health conditions they develop. And those factors in turn influence what kind of outcomes they may experience as they age, whether it's ADRs, adverse drug reactions, falls, frailty, and more. You can see here how you can't treat the diseases without taking into consideration all 4M's, as well as multi-complexity and the social determinants of health. And the reason for that is somebody who is a fit older person is going to be much more able to deal with whatever challenges diabetes throws their way, whereas someone who is already frail, already dealing with multimorbidity or geriatric syndromes or social determinants of health that have stacked the deck against them, they're going to have a much more difficult time weathering the challenges that diabetes may throw their way and bouncing back from that insult. So I'm going to pause here and see what question folks have about the 4M's model and how it applies to diabetes. And then if there are no questions, we'll move on to applying it specifically to the annual wellness visit. So let me just pause for a moment and see if there are any questions or comments so far. And I invite you to do a chair stand just so you're not sitting for a whole hour. And I can't see you, so you can feel free to do chair stands, stretches. We all need to keep our mobility going. Okay. So now we're going to transition and think about the specific structure of the Medicare Annual Wellness visit. And this is a really important one for us to know because it's the major way that most older adults in this country get their health care and access their care as they age. And as we said, 75% of older adults are either living with diabetes or with pre-diabetes. So this is really pretty much everyone that we want to apply these principles to. So the idea behind the Medicare Annual Wellness Visit, in case someone's not familiar with it, is that this is a covered visit once every 12 months that is free for the patient. And the goal of this visit, slightly different from a routine history and physical, is not just to go through the motions of listening to the heart and lungs, but actually to come up with a personalized prevention plan and perform a health risk assessment. There are many different aspects of the annual wellness visit that are required, including gathering a self-report from the patient. And Tiff has put in the chat the link that describes more about what the annual wellness visit is meant to include. I'm going to go through the 12 components of the annual wellness visit and put them in the context of what we've just discussed around diabetes and the age-friendly approach to care. The first aspect that's required of the annual wellness visit is to update the family medical history and the personal medical history. As we've seen, older adults are more likely to have diabetes be one of many medical conditions they're dealing with. So keeping an up-to-date list is critical because if that person living with diabetes has developed in the last year, developed Alzheimer's, developed vision impairment, developed falls, the provider needs to know about that and incorporate that into the personalized prevention plan. Same thing with the family history, because we know that diabetes often runs in families and can predispose to risk. So that's very important to know about, both for the older adults' health and also so they can counsel their loved ones to get the care that they need. Many older adults with multimorbidity have fragmented care, as we saw in the patient priorities care example. And so establishing a list of current providers and suppliers is critical because it makes sure that we know who they're seeing, where they're getting their meds from, and so that we don't result in safety issues from different people telling them what to do. I see a great question from Bonnie in the chat. Why doesn't the annual wellness visit include an annual physical? And I will briefly answer to say that the annual wellness visit is meant to take the best parts of the annual physical, but get rid of the ones that have not been shown to benefit patients. So rather than doing a routine physical that checks everything for every patient, the annual wellness visit is meant to be more focused for older adults making sure that we attend to all the aspects that will make a difference in their care as they age. So while for many patients, it might look pretty similar, an annual physical to an annual wellness visit, the goal is different. The goal is to make sure that we've done the 12 steps I'm going to provide here, which will likely include a focused physical exam, but really think more broadly about a personalized prevention plan and health risk assessment. And so I think I've answered the question that's in the Q&A as well. And keep the questions coming because these are great. Now, step 3 of the annual wellness visit will look very similar to an annual physical, right? Height, weight, BMI, blood pressure. This is going to give us a sense of how the person is doing, whether they're at higher risk for diabetes because they're becoming overweight. And we do know that it is very common for older adults as they age to gain in weight, but lose muscle mass. And so BMI isn't always the best measure of what their muscle mass is, but keeping an eye on overall weight loss can be super important because sometimes older adults will lose weight because they're developing cognitive impairment and they can't manage their meals. Sometimes older adults are losing weight because they've got a cancer that hasn't been diagnosed yet. Sometimes they're losing weight because they need to see a dentist and they're not chewing their high protein meals anymore. So thinking broadly in this category is going to be so helpful because we know that nutrition is so critical to our overall health and especially to our diabetes care. Step 4 of the Medicare Annual Wellness Visit is to look for any cognitive impairment. Now, when we talked about the Mentation M, we gave the example of the mini cog as a quick way that during an annual wellness visit, you can check if someone has cognitive impairment. A normal mini cog doesn't rule out cognitive impairment, but it makes it much less likely. It's pretty sensitive at picking up cognitive impairment. But in many cases, a longer test, such as a MOCA, will be needed, as well as a more thorough workup to determine the cause of any cognitive impairment. Step 5 is reviewing depression risk factors. As we said, two-way street for people living with diabetes. And so detecting depression or other mood or mental health disorders is a critical piece of the annual wellness exam for older adults and those with diabetes. Moving on to step 6, reviewing functional ability and safety, including hearing. So as we've discussed, that mobility M includes things like your activities of daily living. Can you bathe yourself, dress yourself? Can you trim your toenails? Can you manage your medications? If not, what kind of support do we need to get for you so that you can manage on your own? I'm going to give an example from this to hopefully make it memorable. In my own practice, I've taken to always making sure to look at the feet of the older adults I care for. And some of you may have read Being Mortal by Dr. Atul Gawande, who's a faculty member here at Harvard Medical School. He describes a visit to a geriatrics practice in his book where a geriatrician saw a very complex, an older woman with very complex medical problems. And instead of going through medical problem by medical problem, he spent much of the exam looking at her feet. And the geriatrician here describes you must always examine the feet. So I'm just going to give you a way to remember the importance of checking functional status in older adults using the feet, because I think it's a good way to remember it. So I invite you to get into whatever position you would get into. If you were going to put on your socks or trim your toenails, again, I can't see you, but I imagine that most of you are doing the crossover position or maybe the parallel position. Some of you may have your foot up on your desk. But regardless, all of you will need some degree of mobility or dexterity to be able to do this without help. Some of you may use a sock donner to get your socks on because you've got mobility issues or you're 9 months pregnant or whatever it is that makes it hard to reach your feet. We've done some studies in our clinic where we found that the long toenail sign is often a hidden indicator that someone is having trouble with mobility. This is a picture here of a patient who was one of the 18% of patients in our clinic who had this long toenail sign where it had been months since they'd been able to care for their toenails, but they weren't able to access the care that they needed. I mentioned the long toenail sign because we've done some work on thinking about that long toenail sign. We're anyway looking at the feet in people living with diabetes. Okay, they might not have any skin breaks or ulcers, but those long toenails are going to pose a risk for the person living with diabetes in terms of their foot health and the risk of ulcers and amputations, but it also serves as an A1C of how their functional status is. So if you're familiar with diabetes care, you know the A1C well, because it refers to that 3-month measure of blood sugar control. And we like to argue toenails grow 2 millimeters a month. So over the course of 3-6 months, if you develop that long toenail sign, that's showing not only are you having some sort of mobility or vision or dexterity problem, you're also having difficulty accessing the help you need, getting a loved one to help you, getting to a podiatrist or a nail salon. So we like looking at the feet, not only with an eye towards diabetes care, but also helping us think about our overall functional status and how an older person is doing. So that brings us back to the functional ability and safety. And it also reminds us to check hearing. So hearing is often overlooked in older adults because you can imagine if they've got so many other problems and the hearing loss is mild, well, maybe it's not such a big deal. It can wait till next time. The problem, though, is that hearing loss is easily treated, especially if there's wax in the ears, which happens more as we age, or especially if they need hearing aids, though those can be difficult to afford outside of the VA. Treating hearing loss can improve memory and can improve mood, both of which are so important for people living with diabetes. So a quick finger rub test, you can try it yourself, will tell you whether someone is having difficulty hearing you if they can't hear the finger rub from about a foot away. Or just, sending older adults who have any difficulty, especially with the masks that we need to wear in most healthcare settings, sending them for audiology evaluation. Now, these first 6 steps are all to enable the provider to come up with an appropriate screening and prevention checklist. So that might mean checking the A1C in someone who's overweight. It might mean sending someone for a colonoscopy in someone who is losing weight. But it's about coming up with a personalized checklist that matches the older adult's goals, values, and health status. Step 8 has to do with the individual patient risk factors where interventions are indicated. This is where you would do the rest of that physical exam. Oh, they're having shortness of breath. Well, I've got to listen to their heart and lungs. I've got to send them for a chest x-ray. That's step 8 is where all of that medical decision-making is going to happen. Step 9 is the personalized health advice and counseling. This includes things like nutrition, like exercise, like alcohol use, like smoking, making sure that the older adult is getting counseling to help them with their overall health and with their diabetes health. Steps 10, 11, and 12 are relevant to all older adults. Advanced care planning, as we've discussed, is an important thing that everyone should have on file, but especially someone living with diabetes who's at a higher risk of a heart attack or a stroke. They should all have a healthcare proxy and some documentation of what their wishes would be in an emergency, whether that's a PULSed form, which is a life-sustaining treatment form. In Massachusetts, it's a MOLST. Different states, it's called different things, or a living will. Step 11 and 12 are high priorities nationally to make sure that opioid prescriptions or substance use disorders are detected and monitored so that patients get the care they need. And of course, diabetes is just going to complicate all of these things and vice versa. So let me know what questions you have, but hopefully you see that the annual wellness visit provides an opportunity to address the 4 M's when it comes to diabetes care and really come up with a personalized plan that can help prevent diabetes or mitigate it in older adults. I'm going to summarize this section on the annual wellness visit and diabetes by emphasizing the importance of an interprofessional team. You've heard me say this over the course of the webinar, but ideal age-friendly care for an older person with diabetes is going to need, your physician or nurse practitioner or physician assistant, and it's going to need a whole interprofessional team, including nutrition, social work, nursing, pharmacy, dental, audiology, ophthalmology or optometry, podiatry, physical and occupational therapy, and more. Feel free to chat in more ideas that I don't have on the slide here. But you get the vision that in order for someone living with diabetes to thrive as they age, it takes a team. It doesn't all need to happen at once, but over the course of months and years, it takes a team to help someone age well while living with diabetes. I see a great question in the chat about an example of a personalized prevention plan. And I also see a question about, does functional ability include the ability to eat, like oral health? So I'm going to answer both of these questions. I'm going to start with the oral health question. Absolutely. So functional status includes things like your activities, your basic activities of daily living. So those are all the things you needed to do to get out of bed and go to work this morning. Those are things like transferring from bed to standing, mobility to the bathroom, being able to go to the bathroom, get dressed, bathe, and feed yourself. Those are all things that if you can't do those independently, you can't really live alone. You need someone to help you. Then there's your instrumental activities of daily living, and that includes things that require more cognitive input. So that would be something like managing your meds, managing your finances, transportation, and so your instrumental activities of daily living. Many of those you could get help with from a distance, but many of them you would need help on site, like if you need someone to cook your meals for you. So eating and feeding fall into both categories because there's an ideal part of eating, which is planning meals, grocery shopping, cooking. And then there's the feeding part, which falls into your basic activities of daily living. So assessing where someone is having difficulty is critically important in someone with diabetes because maybe they can feed themselves. They don't need someone to cut up their food. They're not having swallowing problems. Their teeth are fine, but maybe they need help with the grocery shopping. Maybe they need Meals on Wheels. Maybe they need nutrition to counsel them on what to eat to control their sugars. On the flip side, maybe you've got someone with poor oral health, poor dentition, which in turn puts them at risk of poor glycemic control and complications such as infection and inflammation, which can in turn raise the risk of heart disease. So the two go hand in hand and are such an important part of taking care of people living with diabetes. And so it really does take a team. To answer the question about a personalized prevention plan, so you might have a patient, and this will kind of move us into our next and final part of the session, which is really developing that personalized plan that allows you to find the sweet spot. So you might have an overall prevention plan that includes things like cancer screening tests, like a mammogram, overall health screening tests like a hearing test, a blood pressure check, and an intervention plan that might include things like physical therapy, nutrition, podiatry. So that personalized plan is going to take into account that patient's individual risks and goals. What I'm going to spend the rest of the time talking about is coming up with a personalized prevention plan for diabetes. And the way I'm going to do that is from a workshop we developed called Finding the Sweet Spot. And what we try to do is prevent 5 steps to align the patient characteristics with the treatment goals and with that patient's overall goals, what matters to them. So the 5 steps we're going to review are pictured here. They start with reviewing the diabetes regimen, establishing an A1C goal, discussing the patient's goals, priorities, and preferences, determining what is feasible, and then prescribing or deprescribing. So as we go through each of the 5, and you'll have these slides, I'm going to give you a case example that'll hopefully pull together all the things we've been talking about today around the 4 M's, the annual wellness visit, and coming up with a personalized plan that allows us to find the sweet spot when it comes for caring for people living with diabetes. So the patient we're going to use is Mr. A, who's 87. He has diabetes in addition to a long list of other comorbidities. But we're going to focus here on his diabetes regimen, which involves taking a long-acting insulin, glargine at bedtime, and a sliding scale of insulin aspart between meals. Now, as I've mentioned, insulin aspart can be risky in older adults and quite burdensome. He lives on his own, though he does ambulate with a cane, and he doesn't have any known cognitive impairment, and he performs his own injections. His dexterity is okay. One of the things we're doing is we're reviewing any patient's diabetes regimen, is thinking about the risks and benefits of their individual regimen. So I invite you to put in the chat, what do you think of his regimen so far? And I'll give you a minute to put that in. So while you're thinking about it, I can highlight that in anyone who's 87, insulin becomes higher risk because insulin is cleared by the kidneys. Our kidney function changes as we age. We're more sensitive to fluctuations in blood sugar. As Jean put in the chat, we don't know how's his diet, what's he eating. So all of these things can change as we age. So we want to look at what someone is taking. And I'm not going to go through this in detail, but you'll have this slide that reviews, and this is also in our AGS quick guide, it reviews all the different diabetes medications and flags considerations to think about when you're prescribing oral medications or insulin medications. And so you can really think about how to modify it, as has been put in the chat, to make it easier for the patient. You're going to be thinking about, where does each medication act in the body, and how do those parts of the body change with age? So as we age, our pancreas may secrete less insulin, so we're more likely to develop diabetes. Our liver and our kidneys slow down in terms of their ability to break down medications. We gain more fat and lose muscle as we age, so we have increased insulin sensitivity. And of course, our intestines slow down, and so we may have more difficulty with our carbohydrate absorption. And so a medication like metformin that acts there may be very helpful. Understanding our different insulins and how long or short acting they are can help us avoid high risk insulins like sliding scale that raise the risk of hypoglycemia without improvement in hyperglycemia management. And so what we're really looking at for this 87-year-old gentleman is we want to avoid those medications with high risk of hypoglycemia, because we know that older adults are more likely to develop hypoglycemia because they may not experience the symptoms of hypoglycemia. And so we know that as we age, it can get harder to administer insulin, as we've discussed. And also that coming up with an ideal regimen for older adults may mean simplifying it to lower that risk of hypoglycemia. So to summarize step one, we know that older adults are more likely to experience hypoglycemia, but less likely to have symptoms. So it becomes much riskier. And that can lead to falls and other adverse outcomes. And so we really need to modify that regimen to minimize that risk of hypoglycemia. That brings us to step two. Step two is establishing an A1C goal based on age and comorbidities. And you'll see in the slides that it really varies based on the person's age, functional status, and overall prognosis. In our last couple of minutes, I'll just mention that there are guidelines on how to come up with an appropriate A1C goal based on your overall age and comorbidities. And so figuring out who your patient is and what their goals should be can help you simplify their diabetes regimen and come up with an appropriate goal. Step three is discussing our patient preferences, as we discussed, what matters to our patients, what they're willing to do, and how that affects the meds we choose. What are their preferences, and what is feasible? What can this patient actually manage on their own? How do their social determinants of health and their other conditions affect their ability to manage their diabetes? In this patient's case, we might want to adjust his diabetes regimen. And that brings us to step five, which is prescribing or deprescribing, to simplify his regimen and make sure that it is safe for him. You'll see in the slides, I've included an algorithm for how to think about prescribing or deprescribing. But for our purposes, I'm going to leave you with these 5 steps that allow you to come up with a personalized plan to find the sweet spot for older adults living with diabetes. You'll see in the slide deck, there's a second case that you can click through. But because we're at the end of our time, I'm going to leave us with a summary, which is that our ultimate goal in caring for patients living with diabetes is to make sure that we mitigate the impact, prevent it when we can, and mitigate the impact using an age-friendly approach that takes into account the 4 M's, that uses the framework of the annual wellness visit to deliver that person-centered, age-friendly care for diabetes, and ultimately helps us find the sweet spot for our older adults. So you'll see in the slide deck, I've included references, including our American Geriatric Society Diabetes Quick Guide. I can stay on for a few minutes for questions, but I really thank all of you for your attention today and your participation via the chat and for the opportunity to speak to you about this important topic. Thank you.
Thank you so much, Dr. Schwartz. This was a fantastic presentation with lots of great resources and tools in thinking about how to utilize the Medicare Wellness Visit for diabetes prevention in older adults. And I see we have one question from Jeannie. Can we receive the PowerPoint? And I think you said yes, that you would be open to sharing the slides. So
absolutely, yeah. And I think the team has it on file, so you're welcome to share it. And I also see there's one other question about continuous glucose monitoring in older adults. And absolutely, many older adults will be eligible for continuous glucose monitoring, often taking into account their mentation and their mobility or dexterity is going to be important to figure out if it's a safe option for them, but it definitely should be considered when appropriate. So thanks for that question.
Great, thank you. So thank you to all who attended. Please remember to fill out the evaluation. And thank you again, Dr. Schwartz. This was a phenomenal webinar, and we're really happy that you were able to provide it to us today.
Thank you so much. Thank you for having me.
Yes, and everyone have a good rest of your week. And please reach out if you have any questions. We can certainly pass them on to Dr. Schwartz.